Jim, thank you for that warm introduction. Thank you for the opportunity to come and spend some time with you. This has been some of my first exposure to this organization, and I had the pleasure of having dinner with Jim last night. And it was clear in talking with him and talking with his staff that there is just a clear passion here for what he does, for what the organization does, that they live, eat, breathe, your cause. They are truly here to help you out. And that's very much what we're doing at Stanford also, that I live, eat, breathe, drink, sleep, dream about pain. And my mission, our mission, is to try to help improve the lives of people suffering from pain, to help improve their physical functioning, their quality of life, and ultimately also eliminate or at least alleviate much of the pain they're experiencing. As was mentioned, I work up the road at Stanford. I've been there now for about 17 years where I did my training. I've been on faculty for about 12, and I oversee the clinical, educational, and research missions there. And as Jim mentioned, we have a large interdisciplinary group, and I'm going to show you a couple slides on that at the end, which will be my only little pitch to you about a little bit more about what our program is all about. I was asked by Jim to talk with you about some of the kind of the latest and greatest research and treatments related to it, and I'm going to be focusing on some specific areas. And my goal today is to predominantly educate you, to teach you a little bit more about what CRPS is and what we're learning about it, and to talk about some of the latest and greatest research that we think is going on out there, some of which is available now and some of which we hope to be available in the future. Now, in this day and age of multiple conflicts, and where you never know where somebody's got their hand in somebody else's pocket. We're finding in the academic realm it's traditional to put up our disclosures right up front so you see where the speaker's coming from. And I'll share with you that I have no industry conflicts. I receive no money from industry of any type. All of my conflicts are with the National Institutes of Health. I receive all of my funding. All of my funding is either through the NIH or I have some very generous donors who also fund our research. And in fact, a lot of the studies I'm going to be showing you were not funded by the NIH, but by generous donors, because the NIH tends to fund more conservative, less risky type of research, and that we tend to take a lot of risks in our group. So these are some of the objectives. I've nailed it down into two. I want you to get a better understanding of some of the central nervous system, the brain aspects of CRPS, and what we've learned about that. And then also I want to talk about some novel therapies, some stuff, again, that's available now, and some things that we think are going to be very promising in the future. Before getting there, though, I should share with you that I get all of my current research information from National Public Radio. And so in driving into work, recently, there was a nice survey on NPR about what Americans know about science, and I learned the following. That by and large, Americans believe that H2O is hot water, CO2 is cold water. That water is composed of two gens, oxygen and hydrogen. Oxygen is pure gin, hydrogen is gin and water. Don't ask me what gin and tonic is. Everybody knows this. There's three kinds of blood vessels: arteries, veins, and caterpillars. Gonads are defined as a tribe of wandering desert people. And my all-time favorite, to keep the milk from turning sour, keep it in the cow. All right. I hope the science I'll provide you over the next 40 to 45 minutes will be a little bit more on target. I want to start off with talking about pain in general. There was a recent Institute of Medicine report on the state of pain in this country. The reason I was on the panel, so I co-authored this with a panel of 19 experts in the country, and we were asked by Congress to look at the state of pain as it exists now and where we should be moving in the future. We commissioned what's called an econometric study, which looks at the burden of pain in this country, and we learned that there's about 100 million Americans in this country suffering from chronic pain, 37% of the US adult population. That's more than diabetes, heart disease, and cancer combined. That we spend, it's a $500 billion a year problem. $500 billion a year, of which $100 billion of that is directly through federal funding. That's Medicare, Medicaid, and other federal sources. Huge, huge problem. $500 billion, by the way, is more than we spent in the entire Afghanistan war. And we do this on a yearly basis. It is the #1 reason why people are out of work. And the other statement that we made from the IOM report very clear is that while pain can be a symptom of another condition early on, it can develop and become a disease in and of its own right. And that's going to be a recurring message that I present to you when we talk about CRPS throughout. It's sometimes helpful to start off with a case presentation, a real live person. And this is Kathy. And this is actually her real name because she's given me permission, and she sometimes comes and will talk with me to the medical students. Kathy is she's a 61-year-old Stanford nurse. She worked at Stanford about 20 years. When I saw her, she had been retired from Stanford for a while. But chronic pain in 2 locations, her right foot for about 12 years and her back for many, many years. The pain on her right foot, 12 years ago, she did a lot of river rafting, used her right foot as her primary foot for climbing. She noted her foot went numb, and then went to an orthopedic surgeon. She got EMG nerve conduction studies that were positive for called tarsal tunnel syndrome. If you don't know what tarsal tunnel syndrome is, it's the analog to carpal tunnel syndrome, but it's in your foot and your ankle area here, and it compresses off your tibial nerve. She ended up having surgery 1 year later to release the scar tissue, and the pain came back much more intense. This is the distribution of her pain coming down through here into her foot, and her whole foot and the lower part of the leg was on fire. How many of you can imagine that kind of scenario? Okay, I thought so. She's on medications, currently Effexor, which is it's an antidepressant that we use for treating pain. Kathy was not depressed. We were using it to treat pain. At the time, past medical history, she had breast cancer, bilateral mastectomy, chemo. She's in remission. She's otherwise healthy. Past surgical history, she had the back pain because she was born with severe scoliosis. She had Harrington rods back in the 60s. These are used to straighten out a curvature in your back. And then the tarsal tunnel surgery here. All right, we're going to come back to Kathy a little bit later. Kathy's, again, her major complaint, terrible burning, on fire foot pain. She can't put weight on it. Really has impacted her quality of life and taken a toll on her mood and her family life also. Many of you all know clearly what CRPS is. I only throw this in for an introduction. Group of disorders, I say a complex group of disorders, generally developing after trauma, but not always, and most prominently affecting the limbs with or without a nerve lesion, may develop after some visceral lesions. It consists of pain, abnormalities of sensation, changes in sweating, hair growth, nail growth, temperature, color, affecting deep and superficial structures. Okay, I now want to turn your attention and give you a little background on what I call pain processing 101. Most pain all starts with a stimulus. And so, wait a minute here, Mr. Crumbly, maybe it isn't kidney stones after all. So maybe it's not kidney stones causing this guy's back pain. So turn your attention to this slide that gives us an overview. And this is where I start teaching our pain fellows when they come in on the first day what pain is all about. First of all, let me share with you that what goes on out here, folks, is not pain. This is not pain. If you hit your thumb with a hammer, you cut your hand, step on a tack, it's not pain. It's what we call nociception. And what is nociception? Nociception is what happens when you activate primary nociceptors. These are the transducers that lie in our skin and our soft tissues. What's a transducer? A transducer is nothing more than a device that converts one form of energy into another form. And so this microphone is a transducer. It converts sound energy into electrical energy. And then the speaker converts that electrical energy back into sound energy. In our bodies, we have these transducers that convert mechanical energy, temperature changes. So on a hot day, you go out here, it's activating temperature nociceptors, and we perceive it as hot and painful. And it converts it into an action potential, which is a little electrical signal that's transmitted up 2 different nerve fiber types. And the 2 different nerve fiber types that we have that are responsible for pain, one's called A delta and one is called C. The C fibers are kind of pokey. They're very slow. They're transmitting at about 1 meter a second. The A delta fibers, they've got a nice little bit of insulation around them. They're pretty fast. So let me give you an analogy. Think back to the last time you hit your thumb with a hammer. Can you guys remember that? Twisted your ankle coming off of a curb, stepped on a tack. What happens? You get this sharp jolt of pain that goes right to your brain, right? Those are your A delta fibers firing off. At about 10 meters a second, it takes about 100 milliseconds to get from your thumb to your brain. And then what happens? You have just enough time to think to yourself, oh darn, this is really going to hurt, right? And then you feel this hot, burning, flooding sensation come over your thumb. Those are your C fibers. They transmit at about 1 meter a second, and it takes about a second for a sensation to get from here to your brain along those very slow conducting fibers. And what do you notice with those C fibers? It's hot, it's burning, it's flooding, and for the first time it's unpleasant. Each of these fibers convey ultimately different sensations. Now these fibers, which is not pain, it's nociception, converges into this back part of our spinal cord here. It crosses over to the other side and it heads up into the brain. And it synapses in this walnut-shaped area in our brain called the thalamus. This thalamus is like Grand Central Station. It takes all these signals from our body, converges, and then it sends them out to other parts of our body, our brain, excuse me, to other parts of our brain, where ultimately the perception of pain now occurs. We now perceive pain. And different parts of our brain are responsible for different parts of this experience. Now the story wouldn't be complete if we didn't have some way of controlling these signals. If we were just having to pay attention to all the information that our body was processing on a regular basis, our brains would explode. And so what we've developed over time are what we call descending inhibitory pathways. These are these blue pathways that come down from the brain back down to the spinal cord. And what do? They tell us to not pay attention to the signals that are heading up. Let me give you another analogy. You're probably not paying attention to the feel of the clothing on your back until I just mention it, right? You may not be paying attention to the noise of this fan from the projector until I bring your attention to it. That's because most of what your brain is doing at any given moment is filtering. It's turning signals out so that you can focus attention on things that are important. And that's what happens when it's going right. And in a little bit I'm going to talk with you about what happens when it goes wrong. Let me give you another little data point, and that is this concept of central sensitization. How many of you guys have heard of this concept of central sensitization? A number of you. Okay. Let's imagine we go back to the hand. Let's imagine you cut your hand. What happens after you cut your hand is sharp jolt of pain goes right to your brain, delay, oh darn, really going to hurt, C fibers kicking in, hot burning sensation. A little bit later, after you cut your hand, what happens? About an hour later, you get a release of inflammatory mediators. These are prostaglandins, histamine, cytokines. It's a chemical soup. And what it does is it expands the area that was injured so that you now get the redness and the swelling. This happens after every time we cut ourselves or we had an injury. Every single time. Then what happens? You go to bed, you wake up the next day, and what happens? Doesn't your whole hand feel stiff, aching, and sore? Think about the last time you sprained your ankle. And the next day you wake up and your whole lower part of your leg feels stiff, aching, and sore. Well, what's happened overnight is that your brain and spinal cord have rewired overnight. And it's expanded the area in your brain and in your spinal cord that it's perceiving as painful. If you were to sample the tissue out here, that tissue is totally normal. It's only in here that it's actually injured. Now why would our central nervous system do this to us? Because it serves a survival basis. Back in the cave people days, when we were out fighting the woolly mammoth and the saber-toothed tiger, and if we got injured, it was in our best interest to go sit in a cave and let nature take its course and let things heal up. Because what happened if we didn't go sit in the cave and let nature heal things up and we went out to fight the woolly mammoth when we were injured? Or the saber-toothed tiger? We lose. We got eaten. And if we got eaten, we can't pass our genes down to the next generation. And we're all wired to pass our genes down. And so it served a great survival message. It happens in each and every one of us. This is healthy. This works. Think about this next time you injure yourself. What's going on? Now, in a normal situation, what happens is tissue heals up, zones shrink down, you go back to business as usual, you go out and you fight the saber-toothed tiger. What's happening, we think, in CRPS is that this is not working. This turning off. It's staying expanded, and it expands ever more. And it becomes this centralized problem where it goes over very large areas of our body where we're now perceiving as being painful. What's intriguing about this is that research is now pointing us in the direction that CRPS shares a lot of overlap with other conditions that we're now thinking of as these central sensitivity syndromes. For folks, how many of you are familiar with fibromyalgia? Or irritable bowel syndrome, or interstitial cystitis. A lot of them share the same characteristics with these what we call central sensitivity syndromes, these very large expanded areas that we perceive as being painful. We put labels on them, oftentimes dependent upon which physician we saw first. If it's a urologist, we label it interstitial cystitis. If it's a GI doc, it's irritable bowel syndrome. Sometimes I think of it as the blind man and the elephant, if you know Remember the picture I'm talking about. And so we're learning now that there's a lot of overlap in the mechanisms between these different conditions. What about CRPS? While there's clearly overlap, there's probably some distinctive features of it. We think that CRPS now is a very complex mixture of both peripheral, out here in the periphery, as well as central activity that is becoming disrupted and acting to get into a vicious cycle. You know, neurogenic inflammation, that's nerve inflammation, impairments of the sympathetic nervous system, our fight and flight response, and then coupling between the sympathetic nervous system and our sensory systems, and finally central plasticity. By the way, I'm using the same slides with you folks that I use when I go out and talk with physicians and even specialists. And so what I'm going to try to do is, if it seems like there's a lot of jargon, try to just listen to my voice, and I'm going to work on explaining the terms. And if I don't explain it well enough at the time when there's question and answer, hit me up and ask me more questions about it. In pain, there is a yin and yang, if you will. In all of us, it's just this nice, balanced, homeostatic situation. And if you're healthy, the yin and yang balance out. What do I mean by this? All pain represents a situation of increased information heading up to the brain. We call that facilitation, versus that inhibition that I described earlier. And in a normal situation, if you're sitting here with no pain, they're a nice balance. What can happen is you can either get, in a painful condition, too much facilitation or not enough inhibition. We focused most of our research on this excitation or facilitation aspect. And over the years, we've ignored the inhibition. But we've more recently turned our attention to the situations where there's too little inhibition. Because you can get normal input, and too little inhibition, and you end up with pain. We think in part that CRPS is representing an abnormality of your inhibitory systems. Your brains are not inhibiting in the way they're supposed to. They don't filter well. One of the first things that, again, I teach our pain fellows is that nociception is not equal to pain. Nociception is not equal to pain. What goes on out here is not pain. Pain is a phenomenon of the brain. It's a subjective individual experience, and it's made up of all of these components. We take the nociceptive input, and it ultimately gets shaped. It gets shaped by our cognition. That means our attention, our beliefs, whether we're distracted to or paying attention to pain. Catastrophizing, by the way, is probably the biggest predictor of poor pain outcomes in CRPS and other chronic pain conditions. What is catastrophizing? Catastrophizing are a combination of three things. It's ruminative thoughts about the pain, thinking over and over and over about it. It's amplification of it. This is just getting worse and worse and worse. And the third part is a sense of lack of control of the pain. Clearly been shown to amplify our experience of pain. Our mood, whether we're depressed or anxious, plays a big role. And our individual differences, like genetics. We can't control that. We can't control the genes our parents handed down to us. But we're using that information to tailor our understanding of pain and its treatments. As I said, a lot of this is going on in the brain. I'm a very brain-focused kind of guy. How have we traditionally understood and unlocked the mysteries of the brain? It was just like this cartoon here. Whoa, that was a good one. Try it, Hobbs. Just poke his brain right where my finger is. This is the way we studied brain neurosciences actually back in the day. Neurosurgeons would do open craniotomies, and they would cut out tumors. And while they're doing that, they're looking at your perceptions. And they're looking at what are the deficits that occur. Or they'll go in and they'll stimulate parts of your brain. Well, we can't do that on large scales. And so over the years, we've developed these technologies called functional magnetic resonance imaging, where we can open up windows into your brain to see where pain is processed and perceived. I do a lot of neuroimaging in our labs. I run a systems neuroscience lab. And by the way, since I do brain imaging, I have to have at least one rotating brain in my slide kit. And so that's your rotating brain. That's your rotating brain for the day. This, by the way, is your limbic forebrain system here, folks. This is where your basic emotions are processed and perceived in these middle, old reptilian parts of our brain. This is your fear, your hate, your anxiety, your tension, your love, your happiness, all of that process there. And what we've learned is that a lot of the areas involved with negative emotions overlap perfectly with areas of the brain involved with processing of pain. And so when you're angry or you're tense or you're not getting sleep, we now understand from a neurophysiologic basis where these are linking in and where it's making your pain worse. Each of these brain regions, we're not going to go over a lot of this, serves a different function and plays a different role in your experience, your perception of pain. So I want to talk a little bit about what happens when pain goes bad. What happens when it goes bad? And I want to link this directly to CRPS. And so most of this involves this concept of plasticity, this idea of the changing brain. When I was in medical school, I was taught that after a certain age, after a certain young age, that our brains were basically fixed and they were no longer changing. And I thought that was a pretty depressing comment because that didn't give me much hope as I got older. We now learn entirely wrong. That our brains are incredibly plastic and forever changing from the day we're born to the day we die. And I think that gives us great hope because it allows us to learn new things, to develop new skills throughout life. And there's many adaptive, positive aspects of plasticity. I pulled this study out on neuroimaging where they took London cab drivers and they compared them against not London cab drivers. And what they found is that London cab drivers, by and large, have greater brain volume, gray matter, in the posterior hippocampus. Why this area? This is an area involved with three-dimensional visual spatial area. It's what allows London cab, if you've ever been to London, it's just craziness with all the roads. And so they have to keep these maps in their head to know where to drive. I love this quote from a London cab driver. I never noticed part of my brain growing. It makes you wonder what happened to the rest of it. I thought that was pretty insightful. Okay, but what happens when it goes bad? And let's take a look at the prototypical central sensitivity plasticity situation, and this is phantom limb pain. And phantom limb pain, terrible, terrible condition. Men and women coming back, particularly from Iraq and Afghanistan, they're living now because they're surviving the battles because of the body armor, but they're getting their arms and legs blown off. In a normal situation, this is what's called a Penfield diagram. This is a slice right through this part of our brain here. It's about right here on my side of my head. And you take a cut through it, and it turns out this area, the primary somatosensory cortex is what it's called, maps every part of our body to a particular part of our brain. And it turns out that it's not precisely anatomically related map. In other words, there's a greater representation for those areas where we have more sensation, like our hand and our face. And interestingly, they left off the genitals in this, but the genitals are very largely represented. Are they there?
No, they're there.
Oh, got it, they are there. They're not as, actually, that's not to scale. This was the politically correct version of this diagram. So that's the normal situation. And if you were to unfortunately get your arm cut off, your arm and your leg cut off, it's an interesting scenario. You get this condition of phantom limb pain. You've probably all heard of it. Pain where there's no longer a limb. What's interesting is that if you look at the hand and the face representation, here's the face, here's the hand, here's the upper arm. If you get your arm and hand cut off, the facial representation invades up and takes over where the hand and the arm used to be. If you were to do neuroimaging of a patient with phantom limb pain, you ask them to purse their lips and blow. What you'll find is that they'll get activation, not only in the facial representation, but also in the hand representation. And if it makes for a great physical exam finding for our trainees, if we see somebody in the clinic with phantom limb pain, we ask them to close their eyes, we brush them on the side of their affected face, and what they'll often say is, yeah, doc, I feel you touching my face, but I also feel you touching my phantom hand. Perfect example of plasticity. If you want to read any more, if you'd like to read about this stuff, Ramachandran at UC San Diego did a really nice write-up on this called Phantoms in the Brain and talked about this condition. He wrote that in a very Oliver Sacksian style, if you've ever read Oliver Sacks's books, which also are incredibly well written. Do you need to lose your arm or your hand to have this occur to you? The answer is no. No. And this is a study that was done a few years ago on patients with CRPS. And what they did is they mapped out the first and the fifth digit in that same brain area, the somatosensory cortex. And what they found is that on the normal side here, that there was this normal representation I'm sorry, these are actually reversed. On the normal side, there was this normal representation, but on the CRPS side, there was a shrinking of this representation. That there wasn't as much organization there wasn't as much activity there, suggesting that you can get the same type of effect with CRPS as you do with a phantom limb situation in an abnormal situation. You get just the opposite of this, by the way, if you play the piano. If you're a long-term piano player or you're a string player, you have more manual dexterity, it turns out your hand representation actually gets larger. So intriguing aspect, you don't have to lose an arm or hand to have this occur. Now, one of the things that's only been more appreciated over the last several years is not only the sensory aspect of CRPS, but also the motor. How many of you have noticed kind of alterations in your motor systems with the affected side, or in your loved ones with the affected side, in the sense of if you're going to reach out for a glass or pick out something, do you notice something that's just not quite right in that limb? Any of you? Okay. That has only been more recently been discussed. It's this dystonic type of situation, and what they did here is they studied this with patients with CRPS, and they did videographic monitoring of going out. What they had them do is reach out to a target. Just reach out to a target, that's it. And they videotaped them. And on the normal side, on the control group, normal targeting here, boom. You reach out, pick it up, boom. If you have CRPS, what you find, first of all, is that there's often a delay. There's often a delay to initiate. I see some people nodding their heads. And then there's this little bit of a herky-jerky motion to go pick it up. That's on the videography. What they find is that when you then image people into a neuroimaging environment, you have them just tap their fingers in a scanner. What you find is abnormalities in regions of the brain. This is the somatomotor association area. These are areas involved with motor pre-planning and planning activity. And we find abnormalities there that correlate with the degree of dysfunction in those motor systems. And so we're now beginning to tease apart not only the sensory abnormalities in CRPS in the brain, but also the motor abnormalities as well. There's another way that we're looking at this from a brain imaging standpoint. It's something called resting state connectivity. And what it basically means is the following. Usually with neuroimaging, what we do is we put you in a scanner and we poke you with a sharp stick. And we look at how much brain, we don't really do that, but we poke you or prod you, and then we compare you against baseline. Up until recently, we haven't had a way of just putting you into a scanner and seeing what's going on. Now we can. So we put you into an imaging environment, and we say just lie there and with your eyes closed for about 6 to 8 minutes and don't think of anything. And many of you may be in that state right now, for all I know. And what we can do is, it turns out that in our brains, right now, there's this very slow oscillating set of waves of electrical activity that are connecting different parts of our brains together. It's got a period of 20 seconds. Very slow to connecting different regions of our brain together. And what we can do is we can pull that information out of the brain, and what we did is we looked at a group of patients with CRPS against a group of healthy volunteers, and you can pull these different networks. These are different regions of the brain that are connected to each other, and we can pull them out of this information. And what we find, let me just get you to the soundbite, is that there was one network in particular that was found to be particularly abnormal, and this is called the salience network. This particular network that involved these areas of the brain called the insular cortex and the cingulate cortex are kind of an integrative area that integrates in sensory information with emotional information and then autonomic information. Autonomic is, remember that fight or flight response? And this controls the swelling and the temperature. It integrates all of that together, and we're finding that there were abnormalities in that compared to healthy volunteers. This study, by the way, has not been published. We just analyzed this a while ago and are putting this in. So want to just give that particular disclaimer to you. So we're seeing now, not only are there regions of the brain that are abnormal, but we're now seeing that the way the brain regions talk to each other also has some abnormalities. So that's kind of the bad news, if you will, of CRPS, of how it's affecting the brain, hopefully giving you, some more insights into it. Well, what about treatment? Well, I'm going to switch gears here a little bit. Now we're going to put a little bit of a treatment hat on. And the data is pretty conclusive that when it comes to treating CRPS, the best way to do this is through a multidisciplinary, or the current lingo is interdisciplinary treatment. Interdisciplinary means that we take all of these broad areas of knowledge and expertise and we put it all under one roof. And we say, you guys all work together on this. We bring in pharmacologic approaches, psychological, behavioral, physical and occupational therapy, procedural and complementary and alternative medicine approaches. Does it work? Does it work? And the answer is yes, it works well. Not only does the outcomes data back it up, but let me just show you, since we're on the topic of brain data, let me show you, this is another unpublished study. There was a very young woman who was a flight attendant, came and saw me years ago, and she had hyperhidrosis, sweaty palms. You ever seen these people who, you shake their hands and they're just dripping with sweat? And she was a flight attendant. It wasn't socially good for her during her workplace. So she went in and she had a surgery to clip the sympathetic nerves, and she ended up with CRPS. Terrible, terrible condition, burning pain, on fire, 24/7. We brought her into our inpatient unit, but before doing it, we scanned her brain and we mapped out where her hand is. On the normal side, her hand had the normal representation. On the abnormal side, it had shifted up and moved up into an area that wasn't as normal. Brought her in. We've got one of two inpatient chronic pain units in the country. Physical rehab, medication trials, psychological behavior. I worked a lot on her fear. Terribly, terribly fearful because she didn't understand what was going on. After a couple weeks, markedly, markedly better. We scanned her again. The unaffected hand hadn't changed at all. The unaffected side had moved down into an area that was in a more normal location, giving hope and suggestion that while yes, there are these brain changes, they can ultimately be reversed. They can change back. So I want to take a little bit of a segue now, and I was talking with Jim about this because there's some interest these days in detecting pain, using pain as an objective, using neuroimaging as an objective biomarker or detector of whether somebody is in pain, both to determine whether somebody's in pain, but also what kind of pain they're in, and use it to help guide treatment response. And so there's a strong interest in this, and we're not quite entirely there yet, but we hope to get to the point where we're like this.
The K3 indicator registers a level.
Let me just let me give that a little more volume.
The K3 indicator registers a level of pain. Now watch it as I turn it on. Now that's what he's been going through. I've never seen anything like it. I wonder the poor devils go mad.
All right, don't we all want the K3 indicator? All right, maybe in the 23rd century we'll get it. What we do want are objective biomarkers to be able to determine conclusively whether somebody's in pain, how much pain, and our interest in this is not to replace self-report. I use self-report, I rely on self-report, I'm going to rely on self-report, but there are cases where self-report falls flat. Particularly in clinical trials, we need better ways of determining clinical outcomes. There are also patients who can't provide self-report. The very young, the very old, people in ICUs. The legal system is really interested in this because they're spending huge amounts of money in lawsuits trying to determine pain and suffering. There's been a number of efforts that have been tried to do this, heart rate, skin conductance, EEG, all of it has really fallen flat. The question is, can we ultimately use brain imaging to elucidate this truth? And let me share with you that every brain imaging picture study you've ever seen hasn't gotten at the heart of that. Every study you've ever seen has done the following. We take people who we know are in pain, we stick them in a scanner, and we find out what the brain activity is. We have never to date ever done the opposite. You give somebody a pattern of brain activity and you say, can you determine are they in pain or not? It's kind of this inverse reverse logic situation. So we decided to do this at Stanford, and we applied something called machine learning approaches. And machine learning techniques are really, really cool new area. It's been around for a little while, but it's being applied across all of our society. Machine learning are basically pattern classifiers. They take data and they clump it together into patterns, and then they try to determine with a new piece of information what cluster do you fit into. If you use Google, you type out a search term, right? And it returns something to you. That's machine learning. You go to Amazon and you go buy something. You buy a pair of shoes on Amazon, and you go back the next day, and doesn't it present you with a whole list of things that you would like to buy on Amazon, right? You think, wow, how did it read my mind? It didn't. That's machine learning. That's machine learning. It's now being used in neurosciences to do what's called mind reading. There was a 60 Minutes episode on this last year where we can now, not we, but other people can put people in scanners, and you can determine whether somebody is thinking of a house or a ball or a cat or a fish. And some people have even been doing visual decoding of brain activity to try to recreate a video stream that you're seeing. It's very, very cool. So we applied this at Stanford, and we took 24 people and we trained this machine algorithm on it using eight people on using a noxious thermal stimulus to train this and build this algorithm, and then we tested it on 16 novel people the algorithm had never seen. I was absolutely convinced this would not work. This was motivated by a grad student and a research assistant, and I had said that if we were ever going to get there, this is how we would do it, but I didn't think it would ever work because I thought pain is just too subjective an experience. And they came back and showed me the data. It was just incredible. We had an 87% overall accuracy on this. And we were able to map out regions of the brain that were pretty responsible for pain. And there was one that really seemed to be weighing most of this. So this got a lot of attention, but not everybody was a fan. Not everybody was a fan. We're still trying to win some people over, particularly this guy.
And scientists at Stanford University are now training a computer to detect when people are in pain. You know, how dependent are we getting on technology? Is that really difficult to detect when someone's in pain? Like you see a guy lying on the ground with an axe in his head. You know? Honey, hand me the iPhone. Well, you want to scan this guy. See if I think he's hurting. Yeah.
All right, we'll try and win Leno over. We then took this to the next step and asked, can we determine whether somebody is in chronic pain? And so we did this with 94 people, 47 of which with chronic low back pain, and to make a long story short, with about 76% accuracy, we were able to determine whether somebody was in chronic low back pain. Now, we're not at the point where we can use this as a clinical tool. It's going to be a long way away. I'm very concerned about this technology being abused, and I've been getting into this to try to avoid its potential abuses. There are huge ethical issues associated with this technology about it being misused. I worry about payers trying to misuse this to deny treatment. That's not what this is about and where we're motivated. We're motivated to try to identify new targets to go after to help you out. That's what this is all about from our perspective. So let me now talk about some new novel therapies in this range. And let me just put out some of these disclaimers again. I have no financial interest in any of this. I don't make any money on any of it. Secondly, there's a large number of new promising therapies out there. And as I was scanning through it, it was just overwhelming to try to present it all to you in the amount of time. And so quite frankly, I'm being a little narcissistic, and we're focusing on a lot of the stuff that we did at Stanford. Not all of it. I'm going to show you some work that's also been done at other centers, and then also to put a little appropriate level of enthusiasm. Some of these are very promising and off in the future and not ready for prime time. Some of it is ready for prime time and ready to consider now. So let's talk about one of the first ones that we hope is a future treatment, and that's this idea of learned control of brain activity. And so what we did is we developed where did this come from? What was the motivation for learning how to try to control your brain? And it was motivated for another reasons, but I think this video clip hopefully gives you a sense of that. Maybe not. Oh wait, let's try it again.
Do you know how pain enters the body, Marshall? Do you?
Depends on where you're hurt.
No. It has nothing to do with the flesh. The brain controls pain. The brain controls fear, empathy, sleep, hunger, anger, everything. What if you could control it?
The brain?
Recreate a man so he doesn't feel pain.
So that's what we went out to do. So I've been showing you how we can put you in a scanner, we can get a sense of the brain activity coming out, but what if we turn that upside down? We put you in a scanner, we focus on a particular region of your brain or pattern of activity in your brain, and we fed that signal back to you so that you could see your own brain activity and control it in real time. And like a high-tech feedback. And so that's what we did. And we went into this with the idea of trying to induce neuroplasticity, to change neuroplasticity. And we asked two questions. Can you learn how to control your own brain activity in real time? And two, does it lead to an overall change in your perception of pain? And so we did that, and we focused on an area of the brain. I've been showing this particular area, but haven't really been calling out. It's called the anterior cingulate cortex, involved with emotional modulation and pain modulation and affective response of pain. We fed that signal back to a number of healthy people getting a painful stimulus, as well as, I'll show you, some patients. And we found that with repeated training, that they could learn how to control it. It's like going to a gym, except instead of pumping up your biceps, you're pumping up a region of your brain. And that it led to an overall improvement in your ability to control your pain. This was the healthy data. This was the healthy volunteers getting a thermal stimulus. I took a group of patients. Most of them had CRPS, and some of the fonts here got a little screwed up, but 8 patients with CRPS. And what we did is we fed back on this same one, and we compared it against autonomic biofeedback, standard biofeedback, and we found that the real-time neurofeedback from the brain, significant improvements in overall pain control and reductions in pain compared to the biofeedback. What was also interesting about this is that while some people could do this really well, this is a plot of the ability to control your brain activity versus the change in pain. Some people could hit the ball out of the park. Others couldn't do it if their life depended on it. We're still trying to figure out why and how we can get this to be more useful in a larger group of people. Okay, I've been focusing on the brain. Let me give you just kind of a little teaser on where things have been and what we're learning about the brain and its role also in CRPS. And so this is an old study. 51-year-old man developed CRPS after he had an IV placement in his right hand. He had significant temperature changes, the swelling, fear behaviors, tactile allodynia just means pain to a non-painful stimulus. Think of a sunburn. Think of your CRPS. Unresponsive to multiple therapies. He had a stellate ganglion block, epidural, spinal cord stimulation, meds. Couldn't tolerate physical therapy. Stopped working. 6 months later, he fell and banged his head with a 1-hour loss of consciousness. He did a CT, and an MRI revealed a big hematoma. That's this area here, a bleed in the temporal lobe of the brain. And guess what? He had complete resolution of all of his CRPS symptoms. Complete resolution. He could, completely forgot about his pain in his hand and his arm. He could shake somebody's hand without problems. Now, that's what gives you a sense of the role of the brain. Two things. One is we don't do this therapy at Stanford. Please do not go to your physician asking them to take a hammer to your head over your temporal lobe to try to recreate this. It's just to give you some intriguing ideas about the role, the circular role of the brain within CRPS. But how can we target some of these brain regions? I talked about real-time fMRI, but there is another way now that we have available to us, something called transcranial magnetic stimulation. And this is using magnets in a different way. This takes typically it's called a figure of 8 coil, places it here over the brain, and you're in essence generating a high magnetic field for a brief period of time, which causes a focused little electrical signal change within your brain. And you can both excite an area of the brain and inhibit it, depending upon the parameters. It is limited to the superficial brain structures. You can't get in with current technology really deep. That's changing. We are getting improvements there. But here, this was a study where they looked at it in complex regional pain syndrome just recently using high-frequency stimulation. And what they found is that with repeated stimulation, this is a sham stimulation here. Sham means that they put the coil up and it made the same clicking noises and replicated a lot of the TMS, but it wasn't actually delivering it. And this was over what's called the primary motor cortex also. There was a significant improvement in CRPS symptoms during the therapy. And so that was very exciting. The only downside was that after the treatments, it didn't seem to be particularly durable. It didn't seem to last for a long period of time. So you are seeing sites that are doing TMS. We have a TMS lab at Stanford where we're doing this in healthy people, and also been starting this in patients as well. And we're hoping to find parameters that will provide people with durable benefit. This is, by the way, FDA approved for depression, but not yet pain. And we hope it will ultimately be a viable treatment for pain. Let's get back to Kathy here. She came to see us again in the Stanford Pain Center. We did what's called a multidisciplinary eval. What we do is we have to see a physician, a physical therapist, a pain psychologist, and then we all sit in the room and we eat lunch and we talk about you behind your back. What's actually really cool about this process is that you get sometimes 10 to 20 people, professionals in a room, and after everybody presents, it's a free-for-all. And everybody's kind of throwing in their input from different areas of expertise and different perspectives. And the ultimate output of that is often a beautiful thing because we can converge on a very clear set of diagnoses as well as a treatment plan. And that's the ultimate goal. We recommended a number of different medication trials, and we tried them, but they didn't work for her, except for the Effexor, by the way. We did get some benefit with that, and she remains on it to this day. The physical therapy provided no benefit. There was some clear family stressors with her, and she went to family counseling, which provided some benefit. And then we recommended for some interventions the lumbar sympathetic blocks. They were excellent but provide short-term benefit. Lumbar sympathetic blocks, which maybe you're familiar with, the sympathetic chain, this is part of the nervous system that that controls our fight and flight response and controls the vascular tone in our upper and lower extremities, lies right along the vertebral bodies. And if you put a needle right along, this is coming in from the backside to where the sympathetic chain is, and drop local anesthetic, you can shut that down. And maybe, how many of you have sympathetic blocks? I see a number of you. There you go. And it works for a number of people. It doesn't work for some people. Some people get prolonged benefit. A lot of people only get short-term benefit out of this. And the problem with Kathy is that she only got short-term benefit. It worked, but it only lasted a few days. So what a colleague and I, Ian Carroll and Dave Clark, we had made some observations. We made some observations about this drug called Botox. And maybe you're familiar with Botox. Botox is used to often for cosmetic purposes. It's to take care of wrinkles, right? What's intriguing about Botox is that its whole mechanism is it shuts down a neurotransmitter called acetylcholine. And acetylcholine is this little chemical messenger that is transmitted from the nerve to the muscle. So when you shut down acetylcholine, the muscle goes flaccid, it goes weak, the wrinkles go away. Turns out that that same chemical messenger is used along the sympathetic ganglion. And so we thought, hey, what if we put Botox along the sympathetic ganglion? Will it shut down that messenger, the acetylcholine, and will it provide a long-term sympathetic block? Because Botox works for a long time. It works for months. And so that's what we did. We did a randomized controlled double-blind trial. This was, again, funded through some donors. And what we did is we hypothesized it would provide long-term benefit, and we used return of pain to baseline. This was in CRPS patients. We published this in Annals of Neurology. And this is what we found. And let me explain this graph. This is the percent of people with continued relief. And so what you find is that with the local anesthetic block, large number of people got immediate benefit for the first few days out, but only about 20% of people were still having benefit by about 30 days out. And by 30, 40 days, nobody was having any benefit. Most of it tapered off quickly. With Botox, on the other hand, we were seeing some profound benefit for, in some cases, half the people, more than half a year out, were still getting significant benefit. And so this was very intriguing to us. We do this still at Stanford occasionally. The problem is clearly always the cost in getting insurance authorization. We sometimes work out situations where people just pay for the drug through a local pharmacy. We bring it in and then we inject it in that way. So this needs to be replicated on a larger scale, but we think it offers some hope. Many of you are familiar with ketamine. So Bob Schwartzman did a study. He's out of Drexel. In a group of people, 20 subjects, found, because we're running a little short on time, let me give you the take-home message on this, is that with his protocol here, significant improvement due to the ketamine group. This was pain scores before, and this is the difference between the placebo group and the ketamine group, and you can see a significant difference here. The little asterisk here means that it was statistically significant, and it was very clinically significant. So what Dr. Schwartzman is doing, what we're doing, is we're trying to find out what are the best delivery methods of the ketamine, what are the right doses to use, over what period of time, and in what patients it's going to best work. There's a lot of information here to figure it out. The problem with the ketamine and some of this next drug, one of the other drugs I'm going to show you, is it's been off patent for so many years. No drug company is interested in this, and they're not going to fund it because you can't make any money on this particular drug. So remember I showed you about the resting state changes? You close your eyes, slow alternating waves. David Borsuk out of Harvard looked at this in a neuroimaging environment, and he gave a patient with CRPS, and he worked with Dr. Schwartzman on this, single patient, ketamine, and he looked at changes pre-post. And what he found is, let me just give you the soundbite on this, that before the ketamine, there was abnormalities in these resting state networks, that salience network, the default mode network, another network. After the ketamine, you saw a reversal of those changes. And so we're seeing that with using neuroimaging, we can use it as a biomarker of treatment efficacy and get a handle on where these treatments and these drugs are actually working. Let me close out on now two last studies, one of which is one that we finished up recently. And it involves this, this concept of the glial cells. You familiar? Have you heard about the glial cells and its role? Okay. I got to tell you, when I was in medical, the glial cells are non-neuronal cells. They are hugely predominant in the central nervous system. And what I was taught in medical school is they're just offering a nice warm fuzzy blanket around the neurons. They kind of prop them up and provide structural support. Let's move on. Now we'll talk about the neurons, where it's really exciting what they do. Turns out that approach was all wrong. The neurons are actually key players in linking the nervous system, the neurons, to the inflammatory system, and the neurons to the immune system. And there's been some tremendous work that's been done on the last several years by a number of people. Normally, in a healthy situation, when you're just kind of hanging out, these glial cells, the microglia, are just sitting there minding their own business. And they are just kind of propping up the neurons. But when times of injury, fever, stress, illness, they get activated. They get all supercharged. They get all excited. And they start to migrate, move around, and go to the area where there's injury. And they release this chemical soup, these pro-inflammatory cytokines. And these pro-inflammatory cytokines are involved with the healing process, but they're also involved with generating what we call illness behaviors. If you've ever gotten the cold or the flu, and everybody has, and what happens during that time? You want to feel like you just want to go crawl onto the couch, under the blankets, and have your mom, your dad, your loved one bring you the hot cocoa while you just kind of hang out. Those are normal illness behaviors. We're all hardwired for that, and it's mediated in large part by these glial cells releasing that chemical soup. And after the illness, after the virus has been taken out, after you get better, those illness behaviors go away, you go back to business as normal. In CRPS, and in fibromyalgia, and in irritable bowel syndrome, and in interstitial cystitis, and in chemical hypersensitivity and chronic fatigue, one of the hypotheses are that these glial cells are not turning off, these pro-inflammatory cytokines are still being liberated, and these illness behaviors are still being perpetuated. And so we have this hypothesis. What if we gave a glial cell modulator, a glial cell blocker to people? Would it have an impact on their pain, their fatigue? So we chose fibromyalgia because this was our kind of the first theory. And this was Dr. Jared Younger and I partnered up on this. And he's had a particular interest in glial cells now for a long time. And we took work that has been done by Linda Watkins at Colorado. And I understand Linda has talked for this association before and has done some incredible work. And we decided to use a drug called naltrexone. We wanted a drug that was off the shelf. And naltrexone is actually used as a drug to treat addiction. How many of you heard of naltrexone, by the way? You guys are all out on the internet, aren't you? Checking this stuff out. Naltrexone is used to treat addiction at doses of 50 milligrams. It blocks your opioid receptors. It's used to treat alcohol and opioid addiction. But at low doses, 4.5 milligrams, it blocks the glial cells. You can think of it like aspirin, particularly for the guys in the room that are maybe over the age of 50. If you take aspirin at high doses, it's a good pain reliever. It reduces your inflammation. But doesn't your doctor often tell you to take like a baby aspirin to protect your heart? Because it causes your platelets not to stick together. Two entirely different mechanisms. It's the same with naltrexone. High doses blocks your narcotic opioid receptors. Low doses blocks your glial cells. So we gave this to women, 10 women with fibromyalgia, this ultra low dose, 2 hours before bedtime, and we monitored daily pain, sleep, mood, and function. What we found is, got an incredible result with this, with these patients. We had a baseline run-in placebo and then the drug, and we saw pretty significant improvements. Average reduction of 50% of pain. 7 out of 10 patients were positive responders. Published this in Pain Medicine. This was the most downloaded paper in that journal that year, and I think probably that maybe the next as well. And got a lot of attention on it with only a small number. We have then followed this up, and we've completed a randomized controlled trial. Dr. Younger and I completed a randomized controlled trial of 30 people, and the paper's just been accepted into one of the major journals and will hopefully be coming out shortly. And the results look very much the same. That's fibromyalgia. You might be saying to yourself, yeah, Mackey, but what about what I'm interested in, CRPS? We have not yet studied this in CRPS. I can only tell you anecdotally that I have tried this in a number of patients with CRPS, and in a number of patients I am getting some pretty profound results. And in a number of patients I'm getting nothing. Nothing. And normally I would not be standing up here telling you about this drug because I tend to be very conservative by nature with my treatments, but the good news is we get almost no side effects from this medication. The only thing we got were a couple patients described some vivid dreams for a short period of time while taking it. Some people actually like the vivid dreams. But it's just such a clean drug. It's, they did. It's off patent, it's generic, and it's pretty cheap. It runs about, your insurance company won't pay for it, but it's about $45 a month. We did a little arm twisting of a local pharmacy to compound it. And I usually try it for about 2 months. If it works, great. If it doesn't work, we move on. Let me close out with one last study that we did. Let me just close you with a little happy thought. And that is what I think is the ultimate treatment for pain, folks. And that is love. And I don't mean a live opioid-releasing viral endosome. No. I mean the real thing. All right. So, we all need a little more love. So, I often go to the Society for Neurosciences where you get international meeting about neuroscience, and I often hang out with the guy Art Aaron there, and Art and his wife study passionate love, and I study pain, and the wine was flowing, and Art was talking about, you know, the neural systems in love, and I'm talking about the neural systems in pain, and I had some more wine, and so, you know, has anybody ever studied this? Everybody looked at this linkage between love and pain, between these reward systems in love and the analgesic systems in pain? And the answer is nobody had done that. And so the wine wore off, came back to Stanford, decided to study this. And Dr. Younger was a postdoc at the time, and I offered this study up and said, you know, this is a high-risk, high-yield type of study, and he was a risk taker, decided to take this on. And we worked together on this, and we decided to focus on this early stage of love. It turns out there's several stages of love. This early stage, thought to represent the early, first 9, 12 months or so of a relationship, can be longer, where you feel intense, focused attention on the person you're with. You feel great when you're with them. You think about them all the time. You crave their presence, and when you're not with them, you feel like crap. You feel terrible. Doesn't that just sound like an addiction? And it turns out that, we'll move on from Dion. Turns out the neural systems in love have been characterized, and it is just like an addiction. That when you're thinking about your beloved, that you engage these deep-seated, old brain regions that are involved with your basic drives, hungers, and cravings that are rich in something called dopamine. Dopamine's your feel-good neurotransmitter. It's what motivates and drives us to go and eat, and to go do the things that we enjoy and that we need to do for survival. And it turns out that passionate love engages these same regions, just like as if you were taking a hit of heroin or cocaine, or in my case, dark chocolate. So what we did is we recruited people on Stanford's campus. And what I did is I put up flyers on Stanford's campus. We put up flyers with a very simple message: are you in love? And I got to tell you, within a couple hours, we had over a dozen students banging on our doors saying, we're in love, study us. It was the easiest study we've ever recruited for in my life. I should have done this years ago, because it turns out that when you're young and you're in love, you want the whole world to know about it. And so we asked them to bring in pictures of their beloved. Bring in pictures of their beloved, and bring in pictures of an equally attractive acquaintance. And we had a lot of fun in the lab ranking the attractiveness of all of these people. And we would cause them pain. You know, so we'd have them see pictures of their beloved, we'd cause pain. See pictures of an equally attractive acquaintance and cause pain. And we needed a control task because thinking about your beloved is very attentionally demanding. So we give a word generation task. We ask them to think of every sport that doesn't involve a ball. Think of every vegetable that isn't green, right? It's cognitively demanding. We cause you pain. And so then what we do is we look at this in the lab. And this was also, you know, this is funded by donor support because the NIH wouldn't take on something like this. And what we found is that love works beautifully. It led to a 44% reduction in pain. 44% reduction in pain. Turns out the more in love you were, the more pain relief you got. Now, how did we know how much in love you were? Because there is a scale that measures everything. There's a passionate love scale that psychologists came up with that asks how much of the day are you spend thinking about your beloved. And we had Stanford students that were thinking about their beloved 80% of the day. 80%. It was incredible. And they got 3 times the analgesia. 3 times the analgesia of those who were thinking about their beloved less. We stuck them into a scanner and we imaged their brain. And what we find, lo and behold, this beautiful signature lighting up the nucleus accumbens, this deep-seated reptilian old system in the brain responsible for our drives and dopamine release that was nicely tying in with this area called the periaqueductal gray, which is a brainstem structure that we all have that's one of our endogenous inhibitory areas. You remember the yin and yang? I'm pulling this all back around in circle. The periaqueductal gray is involved with that yang, the inhibition. And it turns out when you're thinking about your beloved, you're cranking up your inhibition. So it works. Love works. Now, what's the take-home message? Well, as a physician, I can't write you for a passionate love affair every 6 months on a prescription pad, right? Maybe unless we were in Vegas. But I can tell you, and I can emphasize to you, to try to go out and do things that are emotionally rewarding. Go do things that are new, that are salient. Go, you know, listen to some beautiful music you haven't heard before. Go for a nice walk in an area you haven't seen. Do something that will engage those reward systems, because we now have a better understanding that they will actually cause some degree of pain relief. So let me close out. Let me close out with Kathy. Kathy ended up coming in for those Botox lumbar sympathetic blocks. She got some great benefit with it. Her scoliosis made it very challenging to do the blocks with her. And so what we ended up doing is we've now transferred over to an entirely new approach on this, in which we're targeting little peripheral nerves that have been injured. And we're finding that by dropping the Botox into those peripheral nerves, that we're getting the same benefit, if not more. And it's a simpler procedure to do. Happy to talk about that later. She comes in for these every 4 to 5 months, and she's back doing very well to her usual activities. Let me close out on a little pitch about what we do. At the Stanford Pain Management Center, I've got about 19 to 20 clinical faculty from all the primary specialties. They're also all pain fellowship boarded as well. They've all gone through a pain fellowship. We all work together under one roof. 4 full-time pain psychologists. We've got a new stunning facility in a large space there. We were awarded an American Pain Society Center of Excellence in 2008 and 2012. You're only allowed it every 4 years. One of only 2 programs in the country to get it twice. And I think some of the big things that we're big on is that we've got a very nice linkage between our research missions and our clinical missions, in that we make sure there's a flow of information going back and forth so that each is informing the other. And I'd be happy to talk more about that. But let me close out for the sake of time. You know, we all know that pain, and particularly CRPS, huge impact on an individual, their family, and society as a whole. We're getting a better appreciation that pain can become a disease in and of its own right, that's stimulated, that's maintained, that's amplified by both peripheral situations, peripheral phenomena, but also by your central nervous system. That brain plasticity is responsible for maintaining and amplifying much of this. That neuroimaging is opening up windows into our brain to see how this is all occurring, and hopefully providing us information about targets in the future. That a multidisciplinary approach to CRPS is the most effective approach, and that we went over a number of novel therapies that can offer hope and treatment for you now, but may also, a number of them, offer you hope in the future. So with that, let me close out, and thank you for all of your attention, and really appreciate the opportunity to be here with you. Thank you.